Question: A 35-year-old woman presents with a 2-week history of gradually worsening shortness of breath and dry cough. She has a history of rheumatoid arthritis treated with methotrexate. On examination, you note decreased breath sounds and dullness to percussion on the left side of the chest. A chest X-ray reveals a large pleural effusion. Thoracentesis is performed, and the fluid analysis shows an elevated white blood cell count with a predominance of neutrophils, a low pH, and decreased glucose levels. What is the most likely diagnosis? A. Parapneumonic effusion. B. Transudative pleural effusion. C. Malignant pleural effusion. D. Tuberculous pleural effusion. The most likely diagnosis for this patient is A. Parapneumonic effusion. This patient's clinical presentation and the characteristics of the pleural fluid analysis are highly suggestive of parapneumonic effusion. Here's the rationale for choosing this diagnosis. Clinical presentation. The patient has a history of rheumatoid arthritis and presents with gradually worsening shortness of breath and dry cough. This suggests an underlying respiratory issue. Physical examination findings. Decreased breath sounds and dullness to percussion on the left side of the chest are indicative of pleural effusion, which is a collection of fluid in the pleural space. Chest X-ray. The chest X-ray reveals a large pleural effusion, confirming the presence of excess fluid in the pleural cavity. Pleural fluid analysis. Elevated white blood cell count with neutrophil predominance. The pleural fluid analysis shows an elevated white blood cell count with a predominance of neutrophils. This is characteristic of parapneumonic effusion, which occurs as a result of an infection or inflammation in the lung, often due to pneumonia. Low pH. The low pH of the pleural fluid suggests an acidic environment, which is commonly seen in parapneumonic effusion. Decreased glucose levels. Reduced glucose levels in the pleural fluid are also consistent with the inflammatory nature of parapneumonic effusion. Now, let's consider the other options. Transudative pleural effusion. Option B. Transudative pleural effusions are typically caused by non-inflammatory conditions such as congestive heart failure or cirrhosis. The patient's clinical presentation, pleural fluid analysis, and history of rheumatoid arthritis make transudative effusion less likely. Malignant pleural effusion. Option C. While malignancy can cause pleural effusions, the predominance of neutrophils and the patient's history of rheumatoid arthritis are more consistent with an infectious or inflammatory process, such as parapneumonic effusion. Tuberculous pleural effusion. Option D. Tuberculous pleural effusion is associated with tuberculosis infection and typically presents with lymphocytic predominance in the pleural fluid. The neutrophilic pleural fluid and clinical presentation in this case are not typical of tuberculosis-related effusion. In summary, based on the patient's history, clinical presentation, chest X-ray findings, and pleural fluid analysis, the most likely diagnosis is parapneumonic effusion. This type of effusion occurs as a result of an inflammatory response in the lung, often triggered by pneumonia or lung infection, and is characterized by the features mentioned above.